Good morning and welcome, everyone. I'm calling the 454th Council meeting to order. Thank you, everyone, for joining us today. Council members, please have your video on during the meeting and mute yourself if you are not speaking. We are live streaming this meeting through the RCDSO's YouTube channel so that members of the public, profession, and other interested parties can watch our proceedings. I would like to turn to the official opening of our meeting with a land acknowledgement. The RCDSO is on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. These traditional lands are known to some as Toronto. Toronto is covered by Treaty 13 with the Mississaugas of the Credit and is home to many diverse First Nations, Inuit, and Métis peoples from across Turtle Island. This land is also part of the Dish with One Spoon territory, a treaty between allied nations to peaceably share and care for this land. We accept our responsibilities to each other and this land we live and work on in a spirit of peace, friendship, and respect. We are committed to actively supporting the necessary work towards truth, reconciliation, and equity. We embrace the role we play in regulating dentists, in protecting the public interest, and in strengthening our partnerships with Indigenous communities to advance access to safe and equitable oral health care. Thank you. At this point, I'm going to turn it over to our Registrar and CEO, Dan Faulkner, to do the council roll call. Dan, please.
Thank you, Hanno. Good morning, Council. As per usual, I will do the roll call in alphabetical order. Patrick Ballantyne.
Here, sir.
Nalan Bhargava.
Present.
Ram Chopra.
Present.
James Colliver.
Present.
Christina Cordero. Christina has resigned. Peter Delane.
Present.
Daniel Fortino.
Present.
Neil Gajar.
Present.
Noha Goma.
Present.
Daniel Haas.
Present.
Iliad Horner-Parvar has sent regrets. Vivian Hu.
Present.
Nizar Ladak has sent regrets. Anthony Licio.
Present.
Anthony Mayer has sent regrets. Harinder Sandhu.
Present.
Adal Simeon.
Present.
Brian Smith.
Present.
Osama Solomon. Osama is scheduled to be here, so we'll note when he arrives. Robin Somerville.
Present.
Rod Stapleforth. So I think I heard a yes. Oh, I see you.
Yes,
Thank
present.
You. Thank you. Mark Trudell.
Morning, present.
Aaron Walker.
Present.
Judy Welikovich. Judy has indicated that she'll be here about 9:30. And Deborah Wilson.
Present.
Thank you. Back to you, Hanno.
Thanks, Dan. And now I'm going to turn it over to Dr. Harinder Sandhu to provide the President's remarks. Harinder.
Thank you, Hanno, and good morning, everyone. So today, I'm very pleased to see you all, Council, RCDSO staff, and all our observers. Thank you, Hanno, again, and good morning, everyone, again. Before I begin, I want to take a moment to acknowledge the strong participation we continue to see at this table. Your preparation and insight shape the work we do. And today we have an agenda that reflects both where we are and where we are headed. I want to begin by highlighting the future-facing work that brings us together today, our continued development of a 10-year vision for the college. You offer thoughtful reflections on the kind of regulator we will become. We must be to serve public interest over the next decade. And again, at our meeting in December, you provided helpful guidance on the articulation of the vision. Council, the capacity we have here to look outward and forward is one of our greatest strengths. It is why we sit at this table. Today, we will have an opportunity to carry that work forward. We will also be turning our attention today to previewing the draft new standard on managing new patients' requests. This is an extra step in our typical process, which will allow Council to explore the concepts that are included in the draft and provide feedback. This is an important piece of work. It speaks directly to fairness, transparency, and clear communication, cornerstone of professionalism and public confidence. As you know, the way practitioners respond to new patient inquiries is often the very first of contact between the profession and the public. The expectation we set must be clear, practical, and rooted in equity. Our discussion today will allow us to inform the development of this new standard. This is just the first time we will explore this topic. It will come back to Council again in April. I'm very much looking forward to your views on this. Council, we move into our agenda. Before we move on to our agenda, I would also like to take some time to recognize several of our colleagues. First, as part of the consent agenda, you will have seen that 2 council members have recently been appointed to new committees. Jamie Colliver, who previously served as chair of the PLP committee, will now serve on the discipline committee. Adele Simeone, our newest council member, will serve on the inquiries, complaints, and reports committee. These appointments will help to fill statutory committee vacancies and ensure continuity. These appointments speak directly to the expertise, judgment, and thoughtful leadership that Adele and Jamie bring. Their service strengthens our governance, and I know they will make meaningful contribution in their new roles. I would like to take a moment to thank Jamie Colliver for his extraordinary service and leadership of the PLP committee for many years. As council members may be aware, Jamie has been an advocate for the program and the staff throughout his tenure as chair, and most particularly during the divestment process. His work on the project review committee was extremely and exemplary and provided great leadership to all of us. Thank you, Jamie. And this is our first council meeting after transition of PLP to Navaccord. I would like to thank the committee that worked so hard to oversee the deal to its completion. Though our work is not yet done, the most historical milestone has passed. My esteemed council colleagues, Jamie Colliver, Anthony Liscio, Mark Trudell, as well as Jeff, Dan, Margot, and Leslie helped to ensure that this project was well guided and successful. Thank you to you all. There were so many other RCDSO staff from finance, registration, IT, HR, and communication staff who played a critical role in making this happen. I would be remiss not to mention the PLP staff and leadership. They brought a high degree of professionalism, through major changes, and made sure that the transition was seamless for dentists. We had excellent advisors from PricewaterhouseCoopers, as always, astute counsel from Wearfolds. Quite simply, this would not have happened without the team of dedicated professionals. Let's give them all a hand. We also have reasons to celebrate 2 additional council members who were recently recognized with awards from their peers. Congratulations to Dr. Neil Gudger on being awarded the American College of Dentists Ontario Section's Outstanding Service and Leadership Award. The award recognizes exceptional contribution by individuals or organizations in the promotion of ethics or professionalism in dentistry. And congratulations to Dr. Dan Hawes on being awarded the American College of Dentistry's Ethics and Professionalism Award. This award recognizes an exceptional lifetime commitment to service and outstanding contribution to dentistry through activity or service within communities, provincially, nationally, or internationally. Council, could we take a moment to congratulate all our colleagues again. Thank you. I want to take a moment as well to welcome all those observing today's meeting, formally and informally. Whether you are joining live or watching the recording, we appreciate your engagement. As you know, transparency is essential to how we serve the public interest. Broadcasting our meetings, making our deliberations transparent, ensuring accountability, these are practices that allow us to maintain the trust placed in us. Before we move ahead, I want to acknowledge council members directly. Your preparation, your willingness to engage with complexity, and the clarity you bring to our discussions are the foundation of a strong governance. To RCDSO staff, thank you. The materials, the analysis, and the hours that go into preparing for council meetings are significant. Your work ensures that we are well informed and positioned to make thoughtful decisions. You keep us focused on our mandate, and we are grateful. With that, Hanno, I'll turn it back to you. Thank you.
Thank you very much, Harinder. Next item on the agenda is the Declaration of Conflict of Interest, which is a standard that is captured in the Ministry of Health College Performance Measurement Framework. I will be asking members of council if they feel they have a conflict of interest, real or perceived, in any of the agenda items today, if they would please declare it at this time.
Mr. Chair, I wish to declare a conflict regarding my appointment to the Discipline Committee. I should withdraw my vote at this time. Thank you.
Thank you. Thank you for that, Jamie.
Yeah, Mr. Chair, I also declare a conflict as I have been appointed to the committee.
Thank you for that, Adele. So both Jamie and Adele will abstain from voting in the next item on our agenda, which is the consent agenda. But I'm just going to pause for a moment to see if any other members of council feel that they have a real or perceived conflict on any of the other matters we are dealing with today. And if that is something that you discover during the discussion, it is not too late to declare it at that time. So there are no other conflicts to declare. I thank both Jamie and Adele for that. Next item is on the agenda is the consent agenda. We will have two votes today on the consent agenda and on the vision statement. We will have time for discussion on the draft standard. As we have previously, we will be doing a roll call for all recorded votes, with the exception of this item, which is the consent agenda. As a governance best practice, we use the consent agenda as a time-saving mechanism. On the consent agenda are several items that are for council's information, acceptance, and ratification. Council will be asked to approve these in a single motion. Council may ask clarification questions about an item on the consent agenda. If members wish to have a conversation about an item, we will take it out of the consent agenda and address it later on during our meeting. I would ask that you use a high bar when asking to remove an item from the consent agenda. The consent agenda items are in your meeting materials, starting from pages 18 to 99. Before I ask for that motion, I would like to note two proposed amendments to the minutes, which is item number 2 in the consent agenda. The first change is to line 95 to correct the spelling of Dr. Haas's name. The second change is to line 96 to note that Dr. Haas stated that there was the potential for a perceived conflict of interest. The proposal is to add the words "the potential" to "for perceived conflict." Are there any questions, council, before we amend the minutes? Seeing none, could I have that motion on the screen, please, Angelo? And the motion is, number 1, that the items that follow from 1 to 6 be approved and or received for information by council, approval of the agenda, approval of the RCDSO council meeting minutes, December 4th, 2025, as amended, council evaluation survey results, December 4th, 2025, RCDSO council workshop plan, council work plan 2026, policy report, and confirmation of committee appointments. And that was moved by Anthony Lisho, seconded by Mark Trudell. And just a reminder that this is the item that both Jamie and Adele will be abstaining from. All those in favor, all the rest of you in favor, please raise your virtual hand. And that is carried unanimously. Thank you very much. You may lower your virtual hands. Thank you, Council. The next item concerns the RCDSO vision. Oh, no, I'm sorry. I am misspeaking. The next item on the agenda is the report from the Registrar and CEO. Dan, I'm going to turn it over to you now, please.
Thank you, Hanno. And I also just want to note for council that Dr. Goma and Dr. Solomon are here, and I think we're still waiting for Judy Welikovich. And thank you very much, council. It's nice to see everybody. I don't have a slide deck today. I try to provide a written report to you quarterly, and this is one of those meetings that is in between the quarterly meetings, but I will provide you with a few updates that have happened since our last meeting and more particularly since the beginning of this year. I know that the president mentioned PLP, and I want to just again confirm the closure of the PLP divestment that took place on January 1st. I sent a note around to council a couple of days after that occurred. There were a few outstanding items. There still are a few outstanding items that we are working on with Navicord and our staff and our team, and PRG, the Procurement Review Group, will have some further involvement. But I want to just confirm that we did anticipate some of the data would not be migrated until January, and that has occurred. That is complete now. And some of the IT components were also dealt with, and those are complete as well. As you know from previous discussions, the loss portfolio transfer that we have only went up to the end of December 31st, 2024. Now that 2025 calendar year is complete, we will be working on the final phase of that LPT for 2025, and that will require the actuarial report, which I understand is underway. So that's still some work that the Procurement Review Group will be involved in. And there's also a joint oversight committee that was included in our agreements with Navicord, where we will talk about issues that we need to address together and also look ahead over the next 3 years while Navicord is involved with the liability malpractice program. And that first oversight committee will take place next week. And that will be myself, Leslie, and Jeff from the college, and 3 representatives from Navicord. So we'll certainly keep the council and executive committee up to date on any issues that might relate to that transaction or that divestment and anything that's at a governance level. I want to turn now to something that you're all familiar with, the annual renewal process. It takes place at the end of every year, where we collect the fees from all dentists, and we also gather information using the survey that we provide to the membership. The survey, renewal always goes over into the new year, into January. There are always late payments, and then when the period runs out at the end of January, there are unfortunately suspensions. This year, we suspended 45 dentists for non-payment. This is very consistent with previous years, so there's always going to be a very small percentage. What I am pleased to tell you about that is that the regulation that was approved that principally focused on the PLP requirements, and that was approved last December, it also included language that would help to streamline the recertification of the reinstatement of dentists who have been suspended for administrative purposes. And so there is a much more streamlined process or efficient process that is taking place this year. The dentist needs to notify us within 60 days of that suspension, And we will obviously look at the information related to that dentist, but by and large, we'll be able to reinstate their certificate of registration very quickly. So again, that was language that we intentionally included in that regulation that was approved last December, and we're seeing now how that works in real time with some of those suspensions this year. I'll turn now to as of right. You've heard from me about this many times, just very briefly. It is a pathway that's included now that enables those who are licensed in other provinces or territories to immediately begin practice in Ontario. And this applies to multiple professions. It started off by applying to 4 professions going back 3 or 4 years ago. And as of January 1st, 16 more professions in Ontario have been brought into that framework, including dentistry. We had a comprehensive briefing note in your package on December the 4th that described as of right the principles, how it was going to work, what we needed to do to get ready. And there was another aspect to it, which was going to be a regulation approved under the Dentistry Act that would enable individuals coming under this pathway to Ontario to be able to use title and to be able to perform controlled acts, even if they aren't registered by the college in those first 6 months of arrival. So those changes have been made not only to the Dentistry Act, but to 15 other health profession acts. And those regulations were approved and filed in December and were in force as of January 1st, 2026. And the main outcomes of that regulation, as I mentioned, is to ensure that any individual that arrives and begins to practice will be able to use the title of dentist and the title of doctor in Ontario, and will also be able to perform controlled acts. One of the risk mitigation factors here is that those arriving in Ontario and able to practice immediately must file a full application and an attestation document with the college. So they will be known to us. And there will likely be a very fast registration process, but there's still that possibility that some individuals would be practicing under this pathway for some period of time, up to 6 months. And I can also share that since January 1st, when this became active, there has been very little inquiry and no uptake on this pathway for dentistry. So we will obviously be monitoring how this pathway plays out and keep you up to date about it as well. We're also involved in some really interesting projects, and we're engaging with a couple of external partners. These are what I would call maybe smaller scale projects, but they are examples of work that I think is a really great alignment with our strategic vision that you'll talk about in a moment, and the system leadership component of that vision. And in addition, they're also going to produce meaningful information for both dentists and for the RCDSO. So the first project is related to a national group that's developing acute dental pain prescribing guidelines. And this is going to use an international guideline development methodology. There will be evidence appraisal, there'll be consensus building, there'll be engagement of endorsement bodies like regulators. And our role is going to be a seat around that table that is really going to help anticipate how that guideline will be implemented in the future with dentists. So things like education, things like whether that translates into any position standards or policies of the college or other dental colleges across Canada. I think for this methodology, what they're trying to do is to bring that expertise in at the beginning rather than develop a guideline and then turn to those who provide education or regulators and say, okay, go and implement. So I think it's a really great process to have those functions involved from the beginning. And Susan Taylor from our college, from our quality area, will be the representative around that table. And we will certainly be keeping the National Federation of Regulators informed about that work. And I'll also comment that Dr. Daniel Haas is a chair and a clinical lead in that group. It is not as an RCDSO representative. It is based on his expertise in this area. So that's a project that certainly will unfold, and I might be able to answer some questions about it, and Dan Haas might as well. The second project that we are close to finalizing is a data sharing and a descriptive project about antibiotic prescribing and use by dentists in Ontario. And we're doing that with the Institute for Clinical Evaluative Sciences. That's ICES, as it's known. And we're going to be able to look at prescribing practices and any variations that might exist. And hopefully from that, we'll be able to really focus on some more analysis of prescribing practices for antibiotics and education that's going to help dentists to focus on appropriate prescribing, and also the broader concept of antimicrobial stewardship, as we're starting to see lots of literature, research, and a greater understanding about the environment and resistance to antibiotics. From a technical perspective, this project is going to involve the consolidation or the bringing together of data sets. So ICES is, as some of you know, ICES is a provincial data and research house. It's involved in many aspects of the healthcare system, and it has access to many provincial and national data sets. And so it will be able to consolidate multiple data sets, including Ontario Drug Benefits, ODB, data sets from Health Canada and others in the province, to be able to look at dentists and to be able to look at, as I described, some of their prescribing practices and perhaps variations. So this is a really exciting project for us. I think while it will give us some information, it might be more limited at the beginning. I think it opens up some real opportunities for the college as part of our system leadership and as part of the use of data to really build out broader health system goals and accomplishments within that. Finally, I'm just going to give you some 3 really quick in-house updates. We just completed internally our annual performance review process for all staff. It started late last year with self-reflections by staff. There are performance reviews for everyone, and that's based on competencies that we've outlined internally, and also goals. And it also includes the point that we're at right now, the development of goals for everyone for 2026. And our philosophy is really that every staff member, even if it's just one goal that's going to improve a process or contribute to the improvement of a process, is extraordinarily useful in becoming a better regulator. We have, and we know this from this year and previous years, we have such a talented workforce here at the college. And the process that we've developed that really requires everyone to participate in goal setting and performance reviews and performance management helps to build engagement. It builds alignment with our strategic vision and our strategic plan and our purpose as a regulator, and it really does contribute to the professional development for all. So we're really, it is a lot of work. I know from hearing from our leadership team, it is a lot of work, but we're continuing to look for ways to make it more efficient and also to yield the benefits that we want from that. Second is RCDSO Connect. I've told you before, this has become a great success story for the college. We're able to communicate with many dentists about work that's really important to them and work that's happening at the college. We've had 2 already in 2026 and another one that's upcoming next week. In January, on January 21st, there was a session on artificial intelligence. On February 10th, last week, there was a session on governance, and coming up next week is a session on record keeping. And then in March, we will be going to Ottawa and doing a live RCDSO Connect. So really great response from the profession. I think it's done a lot to promote transparency, accountability, and I think more importantly, just a real understanding of what we're doing. And when it comes to standards, what are some of those things that dentists can utilize in terms of resources to help them be better practitioners and to incorporate those standards into their practice. So again, we'll always keep you informed about RCDSO Connect and our engagement with the profession. And finally, I want to thank you, Council. You know, as Council members, that every month you get a short cybersecurity training video that allows you to learn something new, and it is really short. It's about 5 minutes. Learn something new and to do a short quiz. And we've had great compliance. And thank you to Angie, who does calls to some of you to encourage you to complete the the vignette before the end of the month. At the end of November, we had 95% completion rate by our committee members, 42 committee members, and we had a 96% completion rate by 23 council members. So again, congratulations, thank you. I want to get 100%. These are really important. I think they not only give you a sense of the things that you need to do to prevent any sort of cyber issues in your college work, but I also think they give you a lot of great tips for your personal use of technology. So please complete these. They come around, they're really short, 5 to 10 minutes of your time, and really packed with great information. So with that, Hanno, I will turn it back to you, and I'm happy to take any questions from council.
Thank you very much, Dan. We do have a few minutes, council, if you have any questions or comments for Dan.
I know it's Rod.
Yes, Rod, go ahead.
Just a comment to Dan. Dan, your RCDSO Connect update was, I felt particularly relevant given some of the strategic directions we discussed in our session last June. And I think it's an excellent start on, developing trust and relationship and showing the membership that we're not just a regulator and that we're looking for a more strategic relationship going forward where there's a to and fro and discussion. Thanks.
Thanks for that comment, Rod. So thank you, Dan. Thank you, council. I see no other hands up. So we will move on to the next item on the agenda, council, please, which is item number 7, the RCDSO vision. The RCDSO Vision 2035, once finalized, will direct and influence the development of the RCDSO's next strategic plan. Together, these documents will shape RCDSO's priorities and deliverables for the next several years. Material on the vision can be found in your package from pages 100 to 107. Senior RCDSO staff have developed a revised draft RCDSO Vision 2035. This draft vision represents Council's feedback and direction from Council's retreat in June of 2025. It also reflects the retreat summary report that Council received. Today, we will focus on the comments and directions that Council provided in December. Andrea Foti, Deputy Registrar and Privacy Officer, will walk you through the documents. And Andrea, I'm going to turn it over to you now, please.
Wonderful. Thanks, Hanno. And good morning, everyone. Pleased to come back to you today with a revised vision document. Hanno, Angela, if you'll just move to the next slide. This is a really nice opportunity, and I hope you feel the same, to kind of engage in that blue sky thinking. Where do we want to go? How do we want to influence and impact the sector and the profession, and as always, work toward serving the public the best way that we can. Angela, if you move to the next one, for today, you've got, as Hanno said, you've got a revised document in your packages. It's at page 105. What I'm going to do is try to be fairly brief. I'm going to give you a little bit of a recap on some background and context. I want to talk you through the changes we've made to the draft vision since your December meeting specifically. And then we're going to allow a lot of time for your questions and discussion. And today we are looking for a decision from you. We're going to be asking you if you approve this draft document as the RCDSO's Vision 2035. So if we move ahead, just to give you a quick snapshot in terms of a recap, this work really started a year ago. In early 2025, we knew we were heading into the last year of our strategic plan, and we started at the senior leadership level to think about and talk about how did we want to approach this work differently going forward. And we wanted to think of new ways to approach it, and particularly new ways that we could engage you at different stages of the process, particularly earlier in the process. So this idea of having an overarching vision document, not just a vision statement, a one-liner, came to be. And that led us to retain the regulators practice, our facilitators, Bradley and Kevin. And together with them and the support of our advisory committee with both Harinder and Nalan and senior staff, we started to think about how we could prepare for a really good experience with council. What were the informational inputs we wanted to see? That took place over sort of early spring, and that led us to our June council retreat. Following that, we had a report released, and I know Angie circulated that full-scale report to you for today's meeting, just as background information. Then over the fall, we worked again with the regulators practice to think about how do we pull all of the great ideas and concepts and feedback that you gave us at the retreat into a concrete document. We had the opportunity to go to the executive committee in October and get some feedback. And then, of course, we went to council in December with that draft document. So if we move ahead, just as a sort of recap, the council retreat, we had a central question for you. Where do we want to be in 10 years? And, you know, I talked about some of the planning and what was the information we wanted to give you to support you in answering that question. There was a range of things, and those are included on the right-hand side of your screen. Each of you had opportunity to meet one-on-one with Kevin and Bradley, and we got great information from you. Kevin and Bradley and their team went away and did some desktop research, jurisdictional scans, literature reviews. We talked to leaders in the field who are doing influential work and got perspective from them. At the retreat itself, we had a fantastic keynote address by Adjunct Professor Stephen Lewis, who really talked to us about, you know, high-level health policy, capital P policy. What are some of the concepts that he was seeing and changes and so forth? And I know many of you really enjoyed that. We got great feedback from you on that keynote address. And then to round it out, we also obtained feedback from our staff. And that was something you asked us to do, and the staff were pleased to offer their perspective. And so each of our leaders did sort of mini focus groups with their teams, and that was fed into the package you got to prepare for the retreat. If we move ahead, as I said, the draft vision is here. You saw it in December. It's back again. And really, it's a changed document from when you saw it. And I'm going to just take you through what those changes have been. So we move to the next slide. Before I get to that, I wanted to just kind of give you a conceptual framework. How does the vision and the strategic plan and then the individual strategic projects under that strategic plan function together? This is a very simple schema, but essentially what you're going to see is really the vision sits as sort of the overarching foundational document. It's really focused on ideas and concepts. So you're going to expect to see not as much detail in that document. It's about what we want to do, ideas, aspirations. Then as we move to the strategic plan, and you'll see in the briefing note, what we're envisioning is that essentially we'll have 2 strategic plans spanning 5 years each that will both serve to advance and achieve the vision. The strategic plan is where we start to get a little bit more concrete. What do we want to focus on? How will we advance on that vision? And then, of course, the most detail comes in those strategic projects. And when we get to that stage, we will work with the types of planning tools and project management tactics that we've done to date. So there will be project charters and timelines developed and KPIs and so forth. And so the projects will really focus on how we do that. What are the tactics? What are the specific deliverables? So that's kind of the way that those all function together. If we move ahead, again, this is kind of a different way of saying it. The vision is trying to answer these questions in sort of the middle of your screen. And so by design, it's short, it's succinct, and is really focusing on concepts. If we move ahead, one further word, and Angelo, if you'll advance on the animation, just wanted to give you a sense, in the vision document, you'll see there are sort of 3 pillars, and those are the same from the version in December. I wanted to just depict for you, how did we arrive at those? We spent some time with Bradley and Kevin really thinking about the key themes that arose from the retreat, and those are in the gray boxes on the left-hand side of your screen. This is Bradley and Kevin's kind of distillation of all of that great feedback and exercises that you did at the retreat. And then we really thought with them, how can we represent those and simplify them into these 3 pillars that kind of anchor us? And so you'll see here, we've landed on kind of, a systems-focused pillar, right touch regulation, and then prepared professionals. So if we move ahead, I'll start to get into what we heard from you in December. And we got some great feedback at the meeting. And I had one council member reach out to me after the meeting as well with some additional feedback. So these are the 6 areas where we've made some changes to respond to your direction. And I'm going to go through them one by one. So if we start with the theme, we heard from you that you'd really like to see an overall theme be captured in the vision. And so on page 1 of the vision, in that introduction section, we really see that middle paragraph, which I've represented here, as serving as the vision. It was a way to tie together in a sentence those 3 pillars and the intention and focus on each of those domains. Now, as we go forward and when this vision is finalized, we'll work with our communications team to develop a shorter, snappier version of this, like sort of a tagline, which we'll use in a variety of ways. But this is how we see the vision being represented. If we move to the next one, we had some good discussion around the term accessibility and its relationship to access to care. And you asked us to clarify that concept. And so we've added a footnote to the vision to really locate accessibility to a foundational framework from authors Penchansky and Thomas around the 5 A's of access. And this was something that did come up a bit in the December meeting. It's a very widely known framework. It's something that our strategic project on access to care has really held as a cornerstone of that work. If we move to the next edit, we heard from you that you were interested in having us reflect the distinct oral health challenges that Indigenous communities and populations face. And so on page 2, under the heading Markers of Success, we've added 2 bullet points specifically to respond to that. And, helpfully too, as you know, under the leadership of my colleague, Michelle Tremblay, we are actively working on a reconciliation action plan. And you'll have a chance to contribute to those efforts later today, but it gives us an opportunity to reflect and acknowledge that work as well. If we go to the next one, relating to prepared professionals, that type of strategic relationship we want to strike with dentists in Ontario and help them adjust to change. We heard from you that it would be really valuable to specifically acknowledge educational institutions as a key partner in that work. So we've added that in on page 3. We also heard from you that you wanted to see the RCDSO's mandate reflected. And what we've done to respond to that, the RCDSO's mandate as it's captured in the RHPA has some legal language. It's to protect and serve the public interest. What we've proposed here to respond to it is a more of a plain language equivalent to try to capture patient-centeredness, the fact that, and I've just given you some language here that you'll see in the vision, but the notion that we'll ensure and work to ensure that the patient remains at the center of everything we do. We thought that plain language would better suit the tone of the vision and make it a bit more accessible to all readers. And if we move ahead, we also heard from you that you really wanted the vision to reflect the importance of data and analytics. And we've worked to weave that throughout the draft. And I've just pulled out here 2 examples of what that looks like so you can see. So bottom of page 2, top of page 3, really setting out the notion that, we hope for the RCDSO to be sought out as a leader on regulatory data, trends, and emerging risks, and that our continuous improvement approach will be motivated and sparked by data, along with some other elements. So in addition to those changes that we've made, you might have caught that the draft vision looks and feels a little bit different. We retained all of the substantive content that we've heard from you over the past several months. But when we went back and made the edits to address your feedback, we really took a fresh look at the language and thought about how could we make it more impactful, more direct, how could we make the sentences a little bit shorter. So together with my colleagues on the senior team, we really went through and made a number of stylistic and editorial changes as well. So in terms of next steps, they really fall into 2 buckets. We've got, once you approve the vision, we'll do a couple of things here. Certainly the Word version that's in your package will not be the final form that it's in. We have some really talented designers that we work with who will package this up in a way that is impactful with visuals and a much more improved layout. And as I said, related to the theme, our communications team will work on developing some taglines and then, go forward and think about the best way to use those going forward. So a lot of this will be in collaboration and under the direction of our communications team and Leslie Byrne. And then the next bucket is our strategic plan, of course. And we've started in a preliminary way thinking about the development of that. We are hoping to come back to you in April Council with a draft. The vision, the revisions to the vision document were a little bit more extensive than we had anticipated. So we'll hope to meet that deadline, but either way, we will update you as we go forward with this work. So with that, as I said, this is the decision before you today. We're asking if you're content to approve this draft document in your package as the final RCDSO Vision 2035. We'll have a motion for you. But before we go to that, I really want to turn it over, if we go to the next one, Angelo, want to turn it over to you. We're looking for your feedback, your questions. I'm happy to answer those. I know Dan is here and happy to do the same, and as is my colleagues on the senior team. And Hanno, I will turn it to you to facilitate, please.
Thank you so very much, Andrea. First person on my list, Harinder.
Thank you, Hanno, and Andrea, thank you so much for taking the feedback and turning it to a great document. I don't have a question. I just want to let the council know that this is just the beginning. This is a preliminary report. We are just approving the framework, and staff will be coming back to us many times. There will be discussion. There might be small group discussion as well. So it's not the final document we're approving. So please keep that in mind, because there will be many other opportunities to for us to contribute. Thank you.
Thank you for that, Harinder. Ram.
Just a comment, I think the document has improved quite a bit from our previous discussions. It included the indigenous part. I'm really pleased with that. So I'm very much pleased with the whole process to come up to this vision.
Thank you. Jamie Colliver.
Yeah, thanks, Andrea, for bringing us this report, and good luck going forward. I know we're focused on Indigenous populations. Have we as a college thought about other vulnerable populations in our sphere? And by that, you can define it as you wish, but there are many populations that don't make it to their dentist or don't have a dentist. How do we communicate to the public that we are responding to vulnerable populations? And maybe we need to make a statement somewhere in our strategic plan that that is a goal to serve as much of the population as possible, including those vulnerable.
Yeah.
Thank you.
Thank you, Jamie. And it's an important point. I think certainly the work we've done to date in our Access to Care project has really been broad-based, and it has really looked at a whole spectrum of different populations who struggle to attain access to care. And we can certainly make sure as we get into the strategic plan development and the specific projects, we can certainly make sure that that's captured going forward.
Thank you. Brian Smith.
Yes, thank you, Hannah. My thanks and congratulations to Andrea and all the folks that have been involved more directly than council in developing this vision for us. I think the theme really captures where we want to be and where we want to try and strive to go to. And I'm particularly pleased with ensuring that the patient remains at the center of all this. So congratulations, Andrea, well done, and please pass on our thanks to others.
Thank you so much, Brian. I will for sure.
Thanks, Brian. Dan Fortino.
Yeah, thank you, Andrew. I think there's great improvements with this vision now. There's definitely essential components of it that are very important. I just wanted to make comment on how and the importance of sort of relaying this vision to both the membership and the public has to be done sort of in a very impactful way. Has there been discussion of how that will be done? How are we going to relay this vision both to the public and the membership, and different ideas on how to do that? Just, I think a blanket document gets kind of overlooked. I think we should come up with sort of ideas on how to really push our vision and make it known.
Yeah, thank you, Daniel. It's a great point. And yes, our communications team under Leslie Burns' direction are starting to think about that. And they'll continue. You know, our focus so far has been on getting the document to a place that council's content, but for sure, we will be thinking about the best way to really communicate this, make sure that it's known. Yeah.
Thank you.
Okay.
Thank you, Patrick.
Thanks, Mr. Chair. Andrea, great work on this, and I realize it is still fairly early days. I wanted to just applaud you on, like, for example, the goal toward plain language with the use of the phrase "ensure the patient remains at the center of all we do." That's terrific. I do think there's an opportunity, given the discussion we had in December on the term accessibility, to perhaps find a better way than the footnote that was used to describe accessibility. As great a definition as that is, it is very academic, and I don't know that it does meet any sort of plain language a goal. So again, recognizing it's early days, but it is something I think is very important, and I just wanted to plant the seed. If there is a way to simplify that, make it a little bit plainer, I think that would be, I think, the document's improvement.
Okay, thank you so much.
Thank you, Patrick. Dan Haas.
Yes, I also want to add, I think you've done an excellent job at incorporating the feedback from December, so thank you for doing that. I think the content is just great. towards the end, you did mention the style of the document, and I have a very trivial comment to make before it is finalized. And I guess at the risk of sounding all elbows up and all that, in the document, the word center is used 3 times. I'm just wondering if instead of the American spelling, which you have now, if we could use the Canadian spelling before it's finalized. But I agree, that's, I guess, in Leslie's department. Otherwise, again, the content is fantastic. Thank you.
Okay, thanks so much.
Thank you.
Hanno,
Yes.
my apologies. I'm having trouble getting my hand signal.
Okay, please go ahead, Rod.
Yeah, great first step, Andrea. Listen, I'm looking back on my June 12th, 13 notes for our retreat, and there's a lot of material that we're gonna, I gather, go through and debate on our next steps. And it's going to be maybe a decision on how best to do this, whether it's in something such as we're going through at the moment, or do we have working groups offline? Because there's a lot of, I think, discussion, things like, our regular, I think we brought up our public interest advocacy, registrant-driven strategy, and I'm reading through strategic analytics and conveners and sustained engagement and corporatization. There's it just begs how we are going to sort of debate some of this going forward to see to what extent we include it. So this will be a challenge. So maybe some comments on how we might do that.
Yeah, thanks, Rod. I think that where I see that coming in is sort of how we craft the strategic plan and what we specifically focus on. So how do we make sure that some of those discrete, concrete issues and areas of focus at the retreat end up having a presence in the work that we do in the strategic plan, both in the plan itself and the priorities we strike for the next 5 years, and then the projects as well. So I think that, once you're content and council's content with the vision, we'll move ahead and do more in-depth work to start developing the strategic plan and those areas of focus. And that's, I think, when Harinder talked about potentially doing some small groups, that's, I think, what we'll look at when we have something for you in terms of a draft strategic plan. We'll think of the best way to engage council in evaluating that and giving us feedback on that. And that may well take the form of some small group work.
Thank you.
Thank you for your question, Rod, and thanks for that response, Andrea. I have no one on my speakers list right now, so what I'm going to ask, Ram, do you have a question? Okay.
Rem is on mute. Was he trying to speak?
Ram, you're on mute.
No, it's okay.
Okay. So what we're going to do is what I'm going to propose is we're going to put the motion on the screen. I'm going to ask for a mover and a seconder, still give people an opportunity if they have a question they want to ask, and then we're going to do a roll call. So the motion is that council approves the draft RCDSO Vision 2035 document, and that's moved by Dan Haas and seconded by Anthony Lisho. I'm going to ask you all to put your virtual hands down because this is going to be a roll call vote, but I'm going to give one more opportunity now that we have moved and seconded that motion to see if there are any questions on that motion. And I have 2 hands that are up. Ram, do you have a question in terms of that motion?
No, sorry.
Okay, so the motion is up. It's been moved and seconded. For your consideration, council, I'm going to be turning it over to Dan to do a roll call. And what council we're asking you to do now is when your name is called, you're either going to respond with a in favor, opposed, or abstain. And then we will announce those results after Dan has done the roll call. So Dan, I'm turning it over to you now, please.
Thanks, Hanno. Patrick Ballantyne.
In favor.
Nalan Bhargava.
In favor.
Ram Chopra.
In favor.
Jamie Colliver.
In favor.
Peter Delane.
In favor.
Daniel Fortino.
In favor.
Neil Gajar.
In favor.
Noha Goma.
In favor?
Daniel Haas,
In favor?
Vivian Hu,
In favor?
Anthony Licio,
In favor?
Harinder Sandhu,
In favor?
Adal Simeon,
In favor?
Brian Smith,
In favor?
Usama Solomon,
In favor.
Robin Somerville,
In favor?
Rod Stableford,
In favor?
Mark Trudell,
In favor?
Aaron Walker.
In favor?
Has Judy arrived?
No, she hasn't.
Okay, thank you. Deborah Wilson.
In favor?
Thank you. Back to you, Hanno.
Thank you. So according to my calculations, and Angie, I'm going to ask you to verify, I have 20 in favor, which means it's passed unanimously. No, 0 no's and 0 abstentions. Do you agree with that, Angie?
That's correct. Yes, I agree.
Okay, so thank you. That motion has been carried unanimously. So thank you, Andrea, to you and your team for that incredible amount of work and for the presentation. Thank you, Council, for your feedback, ongoing feedback and questions. At this point in time, we are a little ahead in the agenda, but I'm aware of the fact that our lunch is going to be shortened. So my proposal is that we will break now until 10:20. So I'll give you a few extra minutes this morning. We'll return at 10:20 to go to item number 8 on the agenda. So I would just ask that you turn off your cameras and mute yourselves, and we will reconvene in this space at 10:20. Thank you very much. Okay, I think we're almost all back now. So I will slowly move to the next item on the agenda, which is item number 8, preview of the draft managing new patient requests standard. And we will have some time now, Council, to discuss this standard on managing new patient records. The information on this item can be found on pages 108 through 113 of your Council package. Access to Care is a strategic project under the 2023 to 2025 strategic plan. Access to care is a broad and multidimensional issue that necessarily involves activity from many strategic partners. The primary focus for the last phase of the project involves setting professional expectations. In 2023, we started implementing Council's direction to develop 2 new college documents to set out expectations for dentists regarding professionalism and accepting new patients into dental practices. The Foundations of Professionalism document was approved by Council in September of 2025. It was developed by a dedicated working group with input from registrants, patients, and other interested parties. And now we turn to managing new patients' requests, another crucial element of advancing access to care. The working group has made substantial progress in drafting the new standard and would like to get Council's initial thoughts on what is being contemplated. And at this point in time, I'm going to turn it over to Dr. Erin Walker, who is a member of the working group. So Erin, over to you, please.
Thank you, Hanno. Good morning, everybody. On behalf of the working group, I'm pleased to bring to you for preview our new draft managing new patient requests standard of practice. Before I preview the draft standard, I'll review a little bit of background on how we got to this point. Then I'll give you an overview of what the working group is proposing. And then I'll highlight our next steps, and we'll turn it over to you for discussion and to receive some feedback. So as you know, and as Hanno mentioned, the last phase of our Access to Care project under the 2023 to 2025 strategic plan focused on developing 2 new college documents. So a working group was struck to assist with the development of these new college documents. And the working group is comprised of dentist and public council members, faculty representatives, and subject matter experts. So council directed that we develop professional expectations regarding professionalism and also accepting new patients into dental practices. We decided to develop the Foundations of Professionalism document first, as it's foundational in nature and has helped to inform the positions in the draft standard for accepting new patients. So Foundations of Professionalism was approved in September of 2025 and was presented to dentists via an online RCDSO Connect session in October, which was attended by almost 2,000 dentists and was a great success. So since then, the working group has also developed some supplemental materials to make this even easier to use. And we're also planning 2 future presentations that have been tweaked a little bit based on feedback and frequently asked questions that have come up so far. So the standard has been very, very well received, and we've received a lot of positive feedback from the public and also from dentists. So as a refresher, you've seen this slide before, so I won't spend too much time on it, but here are the phases of development that the standard has gone through to reach this point. And as you can see, we are at the council preview point. So the working group, to this point, we've reviewed some desktop research, we've reviewed consultation feedback, and we use that information to debate and develop this new draft standard over the course of several meetings and several revisions. So I want to take a minute to highlight how committed the working group has been to this work. So the 9 working group meetings were devoted to considering and discussing the issue of accepting new patients into dental practices. And these meetings have resulted in the really thoughtful draft content being previewed today. So the working group members, we all brought a variety of perspectives to the table. And that allowed us to have really robust discussions where together we tackle questions that really didn't always have easy answers. So we're now at the point in the process where we're almost ready to bring council a draft standard to look at and for permission to consult externally. And then we'll get some feedback that'll make this document even better. And our goal is to ensure that, that this document can provide useful and practical advice that can promote fairness and access to care. So before we do that, we wanted to preview this for you just to get your thoughts up to this point and obtain some feedback from you. So let's turn to what's in the draft document. So this is an outline of how the draft standard is currently structured. So we have an executive summary, introduction, principles. That gives an important overview and context for the draft standard. So then we've organized it into two main sections. So the first section, providing information, outlines dentists' obligations to provide information that helps individuals decide whether a particular dentist or practice is right for them. Then the second session, dentist decision-making, sets out dentists' obligations for managing new patient requests to receive dental care. That is divided into two subsections, so general requirements for non-emergencies and specific requirements for dental emergencies. At the end, there's also a glossary of terms that defines some key terms. So in the draft, we set out dentists' legal, professional, and ethical obligations when managing new patient requests, neither of two situations. So when an individual requests to become a patient of the practice, or when they need care just on an emergency basis. So I'll note, although we use the term dentist, standard is intended to apply equally to general dentists and specialists who receive direct inquiries from potential patients. The draft standard sets out requirements for managing requests that come directly from individuals, and it doesn't apply to referrals from other healthcare professionals, which are addressed in the RCDSO's Most Responsible Dentist Practice Advisory. First off, the draft standard emphasizes the importance of individuals having relevant information about the dentist and about the practice. And this helps them make an informed decision about where and from whom they want to receive care. Secondly, the draft standard clarifies that dentists are not required to accept every individual as a patient in non-emergency situations. However, dentist decisions regarding who to accept must be fair, non-discriminatory, transparent, and clear. And finally, the draft standard reminds dentists that they must continue to meet their existing obligations, both legal obligations under the Ontario Human Rights Code and professional obligations when managing dental emergencies. All right, so on to providing information session. So first off, we wanted to set out dentists' obligations to provide information that helps support somebody's consideration of whether the practice is compatible with their needs and their expectations. So this supports patient autonomy, which is a principle in our foundations of professionalism. So typical information that patients may need to know include things like office hours, registration class of the dentist, so whether they're a general dentist or a specialist, the nature of practice, scope of services available and who provides them, office policies and procedures like scheduling and cancellations, and payment policies such as how insurance claims are handled. So the working group's provisional direction is to include a requirement that individuals receive a response to reasonable requests for information regarding the dentist or the practice. So this type of communication really helps the patient and the office to mutually determine whether a dentist-patient relationship should be initiated, and that is whether the dentist could be accepted into the practice. Or sorry, the patient can be accepted into the practice. So the working group does note that office staff typically provide this information on behalf of the dentists. But dentists are ultimately responsible for ensuring that the information is openly and accurately communicated in accordance with the standard. So again, we want to explicitly state that dentists are not required to accept every individual as patient. The working group recognizes that dentists may have valid reasons for not accepting an individual as a patient, including reasons related to their scope of practice, capacity of the practice, or incompatibility with the patient's stated needs or expectations. However, in this document, the goal is to set out considerations to help ensure that all decisions are fair, non-discriminatory, transparent, and clear. So decisions must be aligned with our foundations of professionalism, particularly in this case, the principles of justice and non-maleficence. So the working group also believes that it's important to highlight the legal obligations that apply to all healthcare professionals, including dentists, when providing services. So we want to remind everybody that they have to provide services in accordance with the Ontario Human Rights Code, which defines 14 specific grounds on which discrimination is prohibited. So although these legal obligations are not new, we recognize that they might be unfamiliar to some dentists. So rather than listing all of these out specifically and in great detail in the document, we're saying that additional resources and information will be put into the FAQ to support this kind of understanding and implementation. All right, so if dentists decide not to accept somebody into the practice as a patient, the working group believes the draft standard should include a requirement for the dentist to provide the rationale for their decision if they're asked. So this promotes transparency and it supports fairness and accountability in decision-making. And it's directly aligned with the core principle of justice that's described in our foundations of professionalism. Working group also believes that the standard should include advice for the dentist to provide the individual with suggestions regarding where they can obtain alternative care where possible. However, the working group doesn't believe that it would be practical or appropriate to go as far as requiring that dentists actually find another oral health care professional who would be willing to take them on as a new patient, because ultimately it does remain up to the patient to pursue their available options. So we are mindful, and we've discussed this quite a bit, as I mentioned in our robust discussions, that it can be practically difficult for dentists to recall like specific conversations with individuals who don't end up becoming patients of the practice. And often these are had with administrative staff and the dentist doesn't even necessarily know. And there's absolutely no requirement to document these inquiries because that would be difficult to do and just not that practical. So in that case, the advice that we're giving is we believe it'd be helpful for dentists to try and remember their rationale if there's a complaint, either to the college or to the Human Rights Tribunal. But we're leaving it up to each dentist to determine an approach that works well for them in their office. So in the standard, we're trying to strike a balance between helping individuals access care, while also making sure that we're not adding a burden of impractical or unreasonable obligations. So our goal here is to promote beneficence, which is another principle of our foundations of professionalism. And we'd love to hear your thoughts on this area, among others, today. Now, for dental emergencies, in advice for responding to requests for emergency care, the working group intends to stay consistent with the RCDSO's existing requirement for dentists to manage dental emergencies for any individual who presents to them with an emergency situation. So this requirement is already found in the RCDSO's Professional Responsibilities for Managing Dental Emergencies article, which was published back in 2015. So managing the dental emergency could include provision of emergency dental care or advising where emergency dental care can be obtained. So In the standard, we have discussed how to handle the relationship after emergency treatment is complete. So the working group recommends that dentists provide patient with following information. So a bit of information to patients who are new patients who visited the office just for a limited emergency treatment. So we suggest that they notify the patient if there's any outstanding treatment needs that were observed during the dental emergency. So this is intended to be a very broad yes or no type of conversation, just based on obvious incidental findings or observations. And it's not by any means a call for detailed diagnosis or treatment planning or specific recommendations. So the idea was just to kind of say, hey, you know, we've tackled the tooth that was bothering you, but I do notice it looks like you have some other cavities in there. So you might want to have those taken care of. So we've also advised that there be a discussion on if the dentist will be providing them with ongoing care, and or how copies of dental records about the emergency can be accessed and how they can be transferred to another dentist if the patient wants to do so. So the working group wants to set out requirements for dentists after the provision of emergency dental care and to help support either the extension or the termination of the relationship. And this sets the grounds for strong continuity of care. So that's the gist of the main points of the standard. So in terms of our next steps, we're planning to bring this back to you in April with a draft version. And we'll be asking in April for your approval to take it out for external consultation. So if we get approval in April, then the standard will be out for consultation from about April to June. And the working group would meet over the summer again to review the consultation feedback and revise the standard again. And then we'll bring it back in December for final approval. So we'll also be developing companion resources such as frequently asked questions, case scenarios, and this will just help support understanding and implementation of this standard in everyday practice. So now I'll turn it over for discussion, and we'd love to get your feedback, your ideas on some of the things that I've highlighted here today.
Thank you very much for that, Erin, and thank you as well to your group, Noah, Brian, and Vivian, for the incredible amount of work that you've done. I'm going to start a speakers list, council, but just a reminder that also on call, Erin, I will sort of let you direct who would be best qualified to answer a question if it is a question. We have Michelle Cabero-Gali, Cam Thompson, and Andrea, who are also capable of chiming in. So between Erin, you and your work group and those staff members, I'm sure we'll be able to address questions that council may have. So Osama, I'm going to start with you, please.
So yeah, great work. Really nice. And great presentation, Erin. Very clear. I'm just wondering if there's going to be information around how this will be integrated with different, and I'd love to hear what Anthony has to say about this too. We have there's the emergency standard, right, for accepting an emergency patient. And then there's a couple of other standards in terms of for accepting patients and the paperwork around that. But I'm just kind of thinking, is there going to be direction on how this can be integrated with some of the other standards that are out there? And then the second thing is there going to be clarification with regards to the specialist? Because, you know, we don't, at least my practice, I'll tell you this, and I would like to hear what Daniel has to say too, but we don't get direct patients come directly to our office. It's almost 100% referral. And is there going to be, I think this would be the room where we could kind of discuss or create some sort of guidance on how the referral should look that's coming from a dentist. And does it meet the specific kind of Like, is there a guidance in terms of how a referral should look? And because that can clarify if things are an emergency or not, if we haven't met these patients. Just a few thoughts. Thanks. Otherwise, amazing. Really, really good.
Yeah, thank you. Maybe Michelle can chime in on this a little bit as well. It's not our intention to override any of the existing standards. So we wouldn't be getting into detail on like what should be included in a referral. But I think the intention is to point to standards that that dentists need to know about when they're doing things like this. So I think that's an area for sure that we can tackle or we can touch on in here.
And if I can just add, Osama, we do have a separate practice advisory on most responsible dentist. So that really covers referrals. So this standard that we're developing on managing new patient requests is really limited to those circumstances where the individual patient comes to the dentist or the practice directly. So we're not talking about referrals in this draft standard. And as Dr. Walker said, we can certainly in the draft standard point to the other college resources that we have on various topics that might be related but not directly addressed in the standard.
If I could just follow up on that too quick. So I'll tell you something we see is we have a referral that comes in, but the referral, but the patient will actually call us. Say, I've been sent to your office and I'd like to initiate the appointment.
Okay.
So I think that there is a significant overlap on that front. And again, the value in integrating it with all the different standards out there that we're doing right now would be obviously super critical, but I think there may be an important part of this where we can kind of explore this in this document as well and how it relates to the other ones.
Sure. Okay, thank you. We can definitely take that back and think about how we can address it, whether it's in the document itself or perhaps in like the FAQs if we need to provide additional direction for specialists in particular. So thank you for your feedback.
Thank you. Harinder?
Thank you, Hanno. Actually, Osama has taken care of all the questions I had, but I think there can be a link with this document directly to the other guidelines from other standards. So I think that problem can be resolved by that, which should be very simple, Erin and Michelle, to just link the other within this guidelines, have the link to other guidelines. People can go and look at it. Thank you so much. It's a great document. I really appreciate the hard work by the group. Thank you.
Thank you. Peter Deline?
Yeah. Hello, Aaron. Thanks for all that work. I'm wondering if in dentistry, if there's a concept of dentist of record. So we see this sometimes in architecture, maybe possibly in engineering as well, where the architect that maybe initiated work at some point, the owner of a building might want to change the architect or might not want to pay the architect and might want a new architect to take over. And I'm wondering if in dentistry, we have kind of the concept of dentist of record, where the new dentist or the approach dentist will kind of hold back a little bit and say, look, are you all squared up with the dentist of record before we talk about this? And perhaps the new dentist or the one who is approached to take on a new patient will have to contact. So how do we contact the dentist of record, and how do we approach them, and what are the things that we make sure are cleared up before we accept that new patient? So that was something that was kind of the concept of dentist of record, somebody who perhaps started treatment, imagine orthodontics or something like that, but perhaps isn't the one who's going to finish the treatment for a variety of reasons. So it'd be interesting to know how to deal with these situations. Thanks.
Thank you. I think that's a good point. So I'm hearing that maybe we could include a provision on communicating with other treatment providers or other oral healthcare providers.
And if I can maybe add to that, Dr. Walker, I think what is being described might already be addressed in our most responsible dentist practice advisory. So it does talk about the concept of the most responsible dentist. So it's not quite the term that you use, dentist of record, but it talks about the most responsible dentist being sort of the quarterback and facilitating continuity and coordination of care between multiple providers. So we can take another look at that, but it might be addressed there, and we can just emphasize that we do have those expectations elsewhere. So thank you for your comment.
Thank you. Daniel Fortino.
Yeah, thanks, Aaron. That was excellent. Just to, Osama took the words out of my mouth for that question, but I want to kind of emphasize I'm in a similar position to Osama where it's strictly referral based. I think there's a disconnect, or the referring dentist doesn't have the proper information to communicate what the referral is for, where it's coming from the dental office or from the patient itself as an individual who's calling, which makes some form of confusion because most of it is limited treatment. I understand, and I've reviewed the most responsible dentist, but I think it's not very clear, and there's so much confusion out there, and it interrupts continuity of care between the specialist and the referring office, that I think that needs to be really highlighted to provide a better service for the patient and to ensure that continuity is clear, and so the patient is not confused. That's one topic. So if there's some sort of link that we can do between the two documents, that would be ideal. And that's one thing that I faced quite commonly that seems to be a big hurdle for the community. Secondly, if there is, and I'm not sure if there's some sort of standard or guideline, if there is someone that walks in to a specialty office for limited treatment, how do we, and they require comprehensive treatment, which we don't provide, is there some sort of guidance for us to send them to referring offices? Do we just let them decide? I haven't read any sort of guideline for the specialist to kind of manage that type of patient. Thank you.
Thank you.
Thank you. Brian Smith.
Thank you, Hannah. I had the pleasure of serving as a public member on this working group. A great deal of work and effort has gone into this, and I think it's encouraging to hear the feedback from council this morning on it. I think it fits very, very well with the strategic directions that we're planning to go, with a little bit of a tune-up here and there. And I want to certainly thank Aaron and Michelle and all the members of the working group for their efforts. I think we've yielded a very good, solid draft project to build with council's input. And want to thank everybody for that. And I keep calling Osama's office to get a referral there, but they never give me a call back. So maybe we can work on that. Just kidding. Well done, Aaron. Well done.
Thanks, Brian, and thank you for your input.
Thank you, Brian. Do you want me to act as a go-between between you and
Yes.
I'll do that at the lunch break. How's that?
All right. Thank you.
Thank you. Mark Trudell.
Yeah, thanks, Hanno. Good morning. Aaron, I echo Brian's comments and those of other council members. Very much appreciate for the great work on behalf of your team, yourself. I want to take the opportunity just to provide clarity or maybe some additional suggestions in response to the comments that were offered by Peter earlier about record of, I guess, whether it's a record of dentist, let alone filed with the registrar. And in Ontario, in the practice of engineering, there's a statutory obligation if an engineer is called upon by a client to conduct a peer review, arguably to get a second opinion in regards to a file. There's a statutory obligation by that practitioner, that licensed engineer, to notify the other licensed engineer, not the regulator, that he or she has been retained to, to carry out that work. Just simply as professional courtesy and arguably to give them a heads up. There is no necessity to file a record as far as the licensed practitioner with the registrar, recognizing, there's tens of thousands of files, and that would just pile on additional reporting and administrative responsibilities on the registrar. But there is, in terms of connecting the dots or the dotted line or the continuity of care and responsibility, there is that requirement, arguably a bit of a self-reporting requirement. I'm just putting it out there as a parallel, and in terms of any guidance that whatever direction you and your team may take on this topic. Thank you.
Thank you. Ram?
Erin, it's a very good document that you're producing. I'm pleased that you have incorporated the Ontario human rights into it. I'm wondering if there is a complaint on that basis. Do they go through the complaint procedure established by Ontario Human Rights?
That would depend on if there was a complaint, which direction the patient took it. So if the patient or any person in Ontario who feels their human rights Tribunal of Ontario, and that's one stream that they can follow.
Right.
If they follow, or if they chose to complain to the college, that's a separate stream. So the college would look at whether the dentist has followed our standards of practice. The college wouldn't be looking at whether somebody's human rights were violated, but we would be looking specifically at our standards of practice, if that makes sense. So it would really depend on which way the patient took the complaint, on how it would be handled and what processes it would go through.
I think that's the patient's choice also. They could go either Ontario Human Rights or they can complain to the college. So
Yeah.
it can, yes, both ways.
Or hopefully not all.
Yeah. Okay.
Thank you. Patrick?
Thanks, Mr. Chairman. Erin, terrific, just terrific work. Congratulations to you and the teams. I'm just responding to something you had said, or I think you had said during your presentation, and that is that, it's conceivable that, my words, conceivable that a dentist won't even know that a patient has approached the practice looking to become a patient. Is there an expectation that or will there be some guidance as to how to best integrate the standards of practice into the dental practice? Recognizing that the dentist, isn't at the front office all the time and making these decisions.
So this was, and Michelle and Cam can maybe weigh in on this, or other working group members as well. This was a discussion that we had in our group, because honestly, this was something that we weren't sure about either. Because we can't require dentists or staff members to make notes on every single call that comes in through the front desk. That's just not practical and not reasonable. So we really landed on just leaving it wide open for this. So I'm envisioning it something or a few things that maybe dentists could do is if they have their policies and procedures like solidly down on paper and those are applied consistently, that would be one way to mitigate this kind of situation. Or another thing, if there is somebody who calls in where, you know, every now and then you just get that gut feel that something's just not going well with a specific call. If somebody's a little confrontational, the front desk could maybe document calls that seem to be out of the ordinary or outliers. So what we wanted to avoid was setting out a checklist of you must do, you know, A, B, C, D, E, F, G. And then if it goes to the ICRC, the panel would be going, oh, did the dentist do this and this and this and this and this and this? So we felt it would be a little easier to leave it open-ended so that if it did reach that point, we would just be looking to see, like, do we think this dentist acted in good faith? Do we think that their policies are fair, non-discriminatory? Were they clear? I don't know if that answers your question solidly, but it may provide a little bit of insight into how the working group tackled this question.
That's helpful, Aaron. Thank you. Yeah, like I say, I'm just concerned that sometimes the dentist isn't ultimately the decision maker as to who the patients are, and I don't even know whether that does happen, but it just feels like it does. So you just want to make sure that these policies are integrated within the practice, whether the dentist is aware of it or not. That's all.
Yeah, for sure. And I think this is an area where we can use case studies or frequently asked questions just to shape this a little bit more. Because I know when this goes out to the public, we'll probably have a ton of, well, what if? So supplemental materials can help a little bit with that decision making as well.
Thank you.
Thank you for that. Osama.
I got two more points I thought of. So just to kind of answer to what Mark and Peter were mentioning, the complicating factor with engineering, right? It's the work is done in the province or in the country. Some dental work is done internationally, so it's hard to reach out to or communicate with like proper continuity of care with some work that's done in other countries. Some dentists actually, when they request like a transfer of records, so I think that may be a little bit of a gateway there, and maybe Michelle and even Cam can kind of with their thoughts on that. But like that could be a nice little gateway in terms of the transfer of records is way of a note. It's kind of a way of notifying. The second thing I kind of thought of was, and I'm not sure if this is in other documents too, so maybe Michelle or Cam, you guys can answer this. Is there a role in this document to include when the patient comes to a new office, like what is their responsibility of the dentist in terms of paperwork? So like signatures, because of the role of AI now, like, I mean, we're even finding this a little bit challenging in our offices because now there's all these transcription software where you go in the room and so again, we do have a standard on this, but is there I don't know if it highlights it as it relates to the initial patient and in the terms of the kind of liability when a patient comes to the office and signing paperwork and protecting the patient privacy and things like that. So just again, food for thought from your standpoint. I'd love to hear your thoughts as well.
Sorry, I was just unmuting. I'm happy to start, and either Dr. Walker or Cam, if you have anything to add. So I think that could be something that we might be able to highlight in guidance or supplemental resources, the intersection between our AI guidance and initiating a new dentist-patient relationship and the things that you might want to consider, especially as it relates to the use of technology, I see that as being like one of the important things that a dentist might want to communicate to a new patient. So in the standard, and Dr. Walker also gave some of these examples, you know, patients or new patients might want to know the office hours, who's going to be involved in their care, how is billing going to be done. And I see that as potentially another example of information that the dentist or the practice could provide upfront. So there's a good understanding at the outset, you know, what the patient can expect from the practice, and the steps that the dentist and the practice are taking to protect personal health information if technology is being used. So I'll just pause and see if anyone else wants to respond to that as well.
Cam's hand is up, so I'm going to go to you, Cam.
Yeah, thanks, Hannah. I'll just comment briefly just to build on Michelle's comment. So thanks, Osama, for the question and for the points you've raised. I think what you're identifying are some really interesting and important points of intersection between this draft standard and other existing college guidance, touching on topics like AI, dental record keeping, most responsible dentists. So just to piggyback on Michelle's comments, we can look at some of those points of intersection just to make sure that they're sort of fully captured and addressed. And as part of the sort of rollout and perhaps the ultimate sort of implementation of this standard when it's sort of closer to its final form, we can look at ways of sort of packaging and highlighting those points of intersection for registrants so that when the standard goes live, they're able to understand where those relationships exist and how to navigate them. So thanks so much for the comments.
Thank you all. Jamie.
Yeah, thank you, Dr. Walker and your team. Very enlightening. I'm hearing mentions of dentists of records and dentist of record and record transfers from one professional to another. Much of this has been, I think, clearly defined in online management or record keeping in the medical profession. It's very easy to look up a patient's history and records are readily available online. Do we see that developing in the world of dentistry?
I would say, just from a clinical point of view, I'm not sure if Osama or anybody who's maybe a little more technologically advanced has a different perspective, but as a general practitioner, it doesn't seem to be something that is that's out there. Every dentist very much keeps their own records, and there's no centralized system. So if a patient wants to transfer to a different provider, there's a procedure they have to go through. They have to consent to their release of records, and then the records can and have to be sent to wherever they want them to go. And that transfer can't be done unless the patient has explicitly consented to it. So there's no means for dentists to access some kind of central e-health database to see where a patient's been or any of their history. So it's very much patient driven, or dentist driven if there's something specific they'd like to know or are interested in a patient's history and what's happened before.
Thank you for that, Erin. And thank you, Council, for all your thoughtful comments and questions. I have 3 people left on the speakers list, so I will go to Robin first, and then Vivian, and then Rod. So Robin, you're on next, please.
Hi, everyone. Great presentation, Erin, and to the whole group. I always kind of bring the I guess, country twist to the question, but, and I am thinking of best interest of the public, access to care and fairness to all. But in the wording of your new patient and the whole document, are you keeping in mind like that the dentist does always have the ability to control access to their practice? And I mean this in the perspective of, in the rural setting, we see this a lot with physicians, but we also see it with dentists. You get dentists that are slowing down in their practice and just aren't taking on new patients. And it's just, they just can't do it. And it is providing access to care for those patients that have them. And it's much better to have them than to have them retire because of the stress of always feeling that they have to take on new patients or they have to be there for every emergency. So if they feel that mental health stress and they opt to retire, we lose major access to care for some people who may have had that doctor or dentist for 30 years. So in the document, are you, and I guess I've experienced a little bit in the rural setting during maternity leaves. I just close my practice and really don't even take, I mean, I kind of always help a kid that might have been hit in a sailing lesson or something, but I really almost close to emergencies because sometimes when I've had mat leaves, I'm just not here as much. So is there just some sort of control in there to maintain access and for dentist mental health to always feel that they're being fair to people or that they have control over their practice in terms of new patients?
Yeah, absolutely. So the standard does say that dentists are not expected to accept every new patient who requests care. And the standard does recognize that there are a lot of valid reasons why a patient may not be accepted into the practice, such as you mentioned, such as capacity issues. But the focus of the standard is just to protect patients and that we want to make sure that a dentist's decision-making is fair, non-discriminatory, and transparent. So in that case, if a dentist is reducing capacity of the practice and is unable to accept somebody because they just they can't accept any new patients, then the standard would really just require that this be communicated to the patient, and also, of course, that this be applied fairly. So it's intended to absolutely leave that flexibility.
Thank you. Vivian.
Thank you, Hannah. Thank you, Aaron, for such a great presentation and answering all the questions. And I was really happy to be part of the working group. We've had a lot of great debates and discussions. And going back to a little bit about Patrick's point, as the gatekeeper, we did say that we're not going to be able to accept everybody that walks in. And they also agreeing with Aaron that we do have a part where there are a lot of scenarios that are brought up. And I think one of them was having meetings with like the most responsible dentists with the team so that the expectation is there. So that's my little input.
Thank you, Vivian. Rod?
Yes, Aaron, great piece of work, very important piece of work. You may have covered this earlier. I'm sorry if I asked something you have already, but are these standards meant, and they're going to be increasingly broad and increasingly detailed and increasingly important to all stakeholders, dentists and public. Are these meant to be documents that we can legally, or various staff or stakeholders can legally refer to in any action taken for and against the college?
I think I'm going to pass that question on to Michelle or even to Andrea, perhaps, or to Cam.
Yeah, I'm not sure. Oh, go ahead. You don't need to answer today. Go ahead, sir, if there is somebody who can. I got a supplement your question.
Are you, just to clarify, are you talking about like the legal enforceability of a standard of practice?
Yes.
Okay. Andrea or legal counsel might be best positioned to answer that, I would suggest.
So, I mean, I can start. I know we have our external counsel, our general counsel on the meeting as well. I mean, I think that, Rod, what all standards do is set out expectations for the profession. Those standards are used by our committees to evaluate dentist conduct. We also have companion provisions in our professional misconduct regulation that speak to the need to comply with standards. So they are definitely used to evaluate and guide assessments of dentist conduct on an individualized basis and to guide decision-making of our different committees. I'll maybe kind of leave it at that. I don't know, Alan or Amy, if there's anything you wanted to add.
Yeah,
or-
I'm sort of asking, can the courts refer to them in any case brought forward as something that's
In a
in my,
civil case, you're
yeah,
talking.
and as an exact as oh, sorry for interrupting.
No, go ahead. I can assist in that question, but perhaps you could clarify if courts
Well,
can rely on them.
Yeah, as an example, what business, many businesses have rules of engagement with their various stakeholders, and they sometimes come in the form of business conduct guidelines, which employees and various stakeholders sign off on annually, recognizing, and it becomes an important part of our liability protection going forward. And just quality assurance. To what extent are we expecting dentists and the public to understand these standards and use them likewise?
So these would be admissible, generally speaking, in court proceedings. These are evidence of the expectations that are expected by the regulatory body for a college, and they are important pieces of evidence. They are intended, as Andrea had mentioned, to set expectations, to evaluate conduct. They're used by discipline committees in evaluating conduct. They are probably also inform at the other end in the training and teaching of dentists. At this point in the regulation of dentists, they may become relevant in the context of civil suits. So they are public documents that are intended to guide, enforce, and set expectations for dentists in the practice.
If not already done so, and I imagine there's a fair amount of onus already, is there a need to review how we roll these out and to the dental community in terms of what our expectations are of them to understand and follow these standards?
I'm going to turn that back to Andrea and Michelle because the college has a very robust process of developing policies that I think they will be more equipped to speak to, but it should address your question.
Yeah, thanks, Amy, and thanks, Rod. Yes, Rod, I mean, to answer your question simply, yes, we do have a plan. We've been doing a lot of work over the past, I'd say, year and a half or so in collaboration with our quality department to really think of ways that we can focus on the implementation of standards. So certainly, once council makes a decision and a standard is finalized and becomes an official standard of the college, our communications team takes a number of steps to advise dentists that that's the case. They're available on our public website. We draw attention to them in newsletters. And then the additional steps that we've been taking and building on is to think in concert again with our quality department. Are there different ways in which we can highlight standards, focus on supporting dentists and understanding practical application of them? So, some of that comes in the form of an RCDSO Connect event. Dan spoke about those earlier. We have held those events specifically on different standards and guidelines. We had one recently on our AI guidance, for example, where we had an expert panel talk about how to apply these in practice. Dentists can get CE points for attending those. We also have a new section of our website that focuses on practice resources, and dentists can gain additional CE points for reading those resources and really thinking about how to integrate those into practice. So it's an area of focus, and I would say we're applying that lens and that work and effort broadly to our standards. And, as a companion to that, Michelle's talked a couple of times, and so has Aaron, about companion resources. They're taking a number of forms. We have frequently asked questions documents. Sometimes we will do case scenarios where we can really pull out and talk about specific fictional cases where we see the guidance applying, and there may be others. We really have a broad approach to that. The goal is to support dentists in knowing what we expect and learning how and really seeing how they can apply that. So I hope that answers
today,
your
Andrew,
question.
is it fair to say these are recommendations on guidance today, not as opposed to mandatory behavior that we expect as a result of them renewing their membership annually?
Are you talking about the content that's in standards or what I'm describing for CE?
I'm being rather extreme, but in some cases in my former life, when we signed up annually to a set of business conduct guidelines that we were expected to read and understand and execute.
Yeah.
Is that something? It doesn't sound like it's the same emphasis. We have more of its guidance, its training, its teaching, its expectation management.
We don't have
it is similar. Like in being registered, you are registrants are agreeing to abide by the standards and guidelines set out to practice the profession. So these standards are a little bit different than some of the other ones because, you know, with ethics, there's more gray area. So that's why we focused on a more procedural way of navigating these situations. Whereas you have other standards that are maybe some of the more clinical standards where it's like, if you're doing a root canal, here's the standard of care. If you're looking at record keeping, here's the record keeping that you need to do. And none of these things can be missing, or you're clearly falling short of the standard. I wouldn't say that these ones are any less important or any less mandatory to follow than those other ones where it is more possible to do the checklists. But these ones are more foundational and a little different, if that makes sense.
And Susan Taylor has put a link onto a website, and I'm really cognizant of the time. So I've got Anthony and Harinder. So I'm gonna ask you
Thank you, everybody. Sorry to delay the meeting.
To be as brief as possible because we need to wrap this up in like 2 minutes. Anthony.
I'm going to be very brief. Thank you very much. It's a great presentation and great work. I did notice, and I wanted to mention that in today's environment, especially with the number of DSOs out there, I don't think this would be a problem. I think if a patient were looking for a new office, they would be welcomed with open arms, and they wouldn't be concerned about a lot of these things that we've been speaking about today. So I wonder if there is no mention of DSOs, there is no mention of dentists, and there are obviously a great number of dentists who are associates working in different practices. They don't have that right to either accept or not accept, especially, like I said, if they're working for a DSO, they're being accepted. Dr. Somerville mentioned that in rural areas, I perfectly agree. That's a whole different aspect, and that is very relevant, and these points are very relevant. So perhaps maybe the committee should think about or look at that part of the dental profession that's pretty significant today and probably growing even more in the future. So just some thoughts. Thank you.
Thank you. Final speaker, Harinder.
Thank you, Hanno. I just want to commend the staff for bringing this preliminary discussion before it comes when we're ready to send it to for wider discussion and feedback. So this is amazing. They all have now, the group has, the staff has all the information which can be incorporated in the final version when it comes to council, and hopefully it will save us time then. Thank you so much again, and for the feedback, everybody and staff and the group, please. Thank you.
Thank you. And a final thank you, Aaron, to you and to your working group for this incredible presentation, and council to you for your thoughtful comments, questions, and responses. If we look at our agenda, the next item should be an in-camera session. We are going to alter our agenda slightly, and we are going to move ahead to items 10 and 11, and then we will go to our in-camera session prior to our lunch break. So at this point in time, I just want to take a moment. We had no indication of any other business people wanting to discuss, but I will briefly look to see if there's anything that someone on council feel needs to be discussed now at a future date. Seeing nothing, I would move on to the next item on the agenda then. A brief reminder to council that our next meeting will be a hybrid meeting on Thursday, April the 16th. We will be meeting in person at Vantage Venues, 150 King Street West, and via Zoom. We will also be live streaming this meeting. Council, thank you for your engaged participation today, and staff, as always, for the incredible amount of work you do at organizing today, organizing all the materials for council to review, and for making this session run as smoothly as it possibly can. Kudos to you. We're incredibly appreciative. In a moment, we will begin an in-camera session, and we will move to that in a moment. After the in-camera session, we will break for lunch, and that will be followed by an education session, and that education session will begin promptly at 12:30. The education session will be about RCDSO's Reconciliation Action Plan, a plan we are working on with First Peoples Group. The goal is to have a plan later in 2026, and council's input is critical. We are looking forward to this reconciliation work, the eventual plan, and the next phase of implementation. Next item on the agenda is to move into our in-camera session. We need to do so because we have a new confidential matter. We will need to approve a motion in order to move to an in-camera session. So if I could have motion 3 on the screen, please. Okay. Council, I don't intend to read it to you, but here's motion 3 on the screen. That's moved by Brian Smith, seconded by Vivian Hu. All those in favor, please raise your virtual hand. And that motion is carried. Thank you very much. To our audience, our viewing public, to save you from waiting for an adjournment, we will do so now because we will then go to the in-camera session. Once the in-camera session is finished, we will break for lunch, and then we will follow that with our education session. So for all those who attended via YouTube, thank you for your attendance and your interest today. We wish you well. And if I could have a mover to adjourn the meeting. Moved by Mark Trudell, seconded by Jamie Colliver. All those in favor of adjournment, please raise your virtual hands. And that motion is carried. Thank you all very much. If you would now lower your virtual hands, please. We will begin our in-camera session shortly. I just need to ensure that